So, guys, welcome along to Diabetes Chat tonight. We have the fantastic Dr. Tom Crabtree as our guest speaker tonight. He is a Diabetes and Endo Registrar and an ABCD Research Fellow working at the University of Derby and Burton NHS Trust. Tom is also current chair of the YDEF committee, and we'll talk a little bit about that, I'm sure, later on. His interests include diabetes technology, type 1 diabetes, and lessons from real-world data, as well as sustainability recycling. Dr. Tom Crabtree was heavily involved in collecting and analysing data from the NHS England closed-loop insulin delivery system pilot, and was a member of the team managing people with the closed-loop systems during the England pilot. And tonight we welcome Dr. Tom Crabtree to Diabetes Chat. We look forward to tonight talking about his career, asking him what his fascinations are working in diabetes, hearing about his role as a registrar. I think that's really important, and it'd be interesting to hear about that. Talking about some technologies, recycling, and we welcome any of your questions throughout the evening. So, without further ado, welcome Dr. Tom Crabtree.
Yeah, thank you for the introduction, and thank you ever so much for the invite to do this. I'm really looking forward to it.
Brilliant, super. So let's kick off then with some fun, quick fire questions. For one, you don't have diabetes, right?
No, I do not have diabetes.
That's fine. So we're going to ask some questions, and some of them might be, if you did have diabetes, what would you prefer? That sort of scenario. So, question one: what is your name and occupation?
So it's Tom Crabtree. I don't answer to Dr. Crabtree. I prefer to be called Tom. It's what I introduce myself to people as. Don't know if that's appropriate or not, but I find it easier. I'm a diabetes registrar working at Derby, also a research fellow, and involved with lots of different organisations as part of my job, and various different other roles. So quite a busy little bee, I think.
Absolutely, yeah, absolutely. If you did have diabetes, what would you say would be your go-to hypo treatment? What would you go for, do you reckon?
Oh, do you know, that's a really difficult question. I think I'd probably go wine gums. I think I'd go wine gums.
Yes, they're great. Them. If you had a choice of insulin pens or pump, what would you prefer, do you reckon, and why?
Well, I'm a tech head, so it would be pumps closed loop all the way.
What do you think's worse, feeling hypo or hyper? And you could see that from two perspectives. One, if you were living with diabetes, how would you feel, do you reckon? And also from a clinical point, what sort of thing do you think is worse? And what do people coming into your clinics kind of say as well? What's worse for them? How do they feel? Hypos or hypers or mixture of both, of course?
I think personally hypos. I think I've had a little bit of personal experience around hypos because I used to have some reactive hypos a couple of years ago. They seem to have disappeared a bit, probably because I've lost a bit of weight since. But even with those reactive hypos, the symptoms were pretty bad. So I have had a few, and obviously not with the same frequency or intensity as people with diabetes, but I have experienced a symptomatic hypo, and it isn't pleasant. And I think as a clinician, I always worry about hypos more. And if I'm seeing someone in clinic, if someone's high, you kind of got a bit of time to play with. You can bring that down slowly. There's things to work on. Actually, hypos are like something we need to get on top of straight away, something we need to really address. And I think, I mean, people seem to, in clinics, say that they have a bigger impact on people's quality of life. Although I do know there's plenty of people who get really significant symptoms with high blood sugars as well. So as you were saying before, I guess every single person with diabetes is unique. It might look different for different people, and but clinically, my concern's always the lows.
What one thing do you like about diabetes, and one thing you don't like about diabetes?
I really like that we see people for a long time, and you really get to build relationships with people. And often in clinic, it's just like catching up with people that you've known for a long time, asking how they are, what's going on. I think building those relationships is really important, and that's one of the things I really love about diabetes. And you can see people at different stages in their lives, and I know things have maybe split out a bit more because you've maybe got young adult clinics and general diabetes clinics, but you see people across the spectrum of their life stages. You know, you see them when they just come up from from pediatric teams. You see them when they're in antenatal clinic and
Yes.
they're pregnant. You see them when they're older. You see them when they have dementia. And you may see them towards the end of life, or support them through complications. So I think that's one of the most rewarding things about working in diabetes. I think there was another part to your question that I've forgotten.
What you not like about diabetes? That's such a great answer of what you do like about diabetes. And I think it's really, I like that. Like, you as a clinician seeing that person on a journey. It's not just that, I don't know, one-off 10-15 minute appointment or whatnot. It's like you see them again and again and again, and hopefully see that journey and help them and nurture them, and also them also help you and have that connection and work together. But what one thing do you not like about diabetes?
So I think and it's not something I don't like about diabetes, but I don't always like other people's response to diabetes. So whether that's to yourselves as people with diabetes, when you overhear those conversations in the doctor's office of MAU and they're using all the words that you shouldn't be using, being like, oh, they're a bad diabetic, they're poorly controlled, that really like cuts through me, because I know we shouldn't be talking that way. And try to have those conversations with people. But when you tell people you work in diabetes, they all go a bit like, oh, diabetes, it's all feet, blah blah blah. And I think they don't really see the complexity or the relationships that you build and the impact that you really have on people. So like, again, that's not something I dislike about diabetes, but I dislike that other people dislike diabetes, which probably means that I like diabetes too much.
Do you think that sometimes people just don't understand about it? And as I don't know if you listened to the welcome chat, but we're talking about James Ridgway with his video that he did under the umbrella, and he was talking about the different types of diabetes: type 1, type 2, type 3C, gestational, monogenic, NDM, modular, stereo-induced, and cystic fibrosis. There's so many types. Do you think people may not know enough? Like, by watching that video, I didn't know about the latter of 4 or 5. And do you think people maybe don't understand it, and they maybe just see as diabetes, and they don't understand, like James says, under that umbrella of what it is, or people's stories behind it, right?
Yeah, I mean, I think there is a lot of that, and I think people reduce it down to something really simple. Like, if you're, I don't want to belittle my colleagues in other specialties, but if you are dealing with someone who's, just trying to think of an example, got high blood pressure. If they take their blood pressure tablets, their blood pressure will be fine, and sure, there's other things they can do that can help. But it's kind of like, they take the tablets, if I don't, it's kind of binary. Whilst with diabetes, it's not as simple as take your insulin and your medications and get on with things, because there's so many other factors, as you were saying before. It's not just your insulin, it's your carbs, it's your exercise, it's the weather, it's the day of the week, it's whether it's a full moon, it's everything else that goes with it. And I think people take a really oversimplistic view of diabetes. And the other thing that I heard you talking about is, like, obviously every person is unique. And just to pick up on that a bit, like, I had a conversation with someone in clinic recently who'd had diabetes for longer than I had been alive, which is often the case because I feel like a bit of a youngster most of the time. But I feel like our role as clinicians is, the person in front of you is the expert in their diabetes, but our job is that we've seen loads of different people with diabetes and learned what's worked for them and what's not worked for them. And so our experience isn't in your diabetes, but it's that we've seen loads of different people with diabetes trying different things and seeing what works. And we know some of the things that are coming through the pipeline that might help. And it's just trying to give people the tools or the guidance that they can then integrate into the management of their diabetes.
Absolutely, like you say, that toolkit, isn't it? Brilliant stuff. And the last question is a bit of a fun one, just to get to know you a little bit more. If you were on a desert island, the Diabetes Chat desert island, what 3 things would you take just to get to know you?
What would I take with me? Oh, that's a really good question. I'd probably take my Switch, so I've got something to do.
Yep.
So I'd take my Nintendo Switch with me. I would. To be fair, if I had a Nintendo Switch, a block of cheese, and a bottle of wine, I'd probably get by okay for a while. Yeah.
You wouldn't be begging to get off the island for maybe a few days, right? You'd be quite happy.
Yeah, as long as the wine and cheese holds out, I think I'd be pretty fine.
Unlimited, right? Okay. So I think that's been a great sort of insight to the start of tonight's guest speaker chat. I think let's look now at your journey of where you have started from to where you have got to becoming a diabetes and endocrinology registrar. So let's start with why diabetes? What fascinates you about diabetes? And before you kind of went into working in diabetes, did you know much about diabetes? Do you know anyone who has a connection to diabetes, whether it's someone living with diabetes or a friend of someone? Like, how much did you know about it, and why does it fascinate you?
So I can tell you my first interaction with someone with diabetes, because the boy who used to sit opposite me in maths in primary school had type 1 diabetes, and the only real memory is this jealousy that he got to eat custard creams during lessons, and me thinking, I don't get to eat custard creams. I want to eat custard creams during lessons, and obviously not having any real understanding of why that was, and retrospectively thinking about it, I was probably on a BD mixed insulin. It was all a bit retro back in the 90s, I guess, wasn't it? And it was probably to stop me having hypos. But that's one of the resounding memories I have.
Wow,
and then
good memory.
And then I seem to have met a lot of people through my life who had type 1 diabetes around just like where I was working when I was a teenager and all that sort of thing. And it never really struck me as something that I would want to do as a job necessarily. And then I went to uni and I found, it's really interesting, diabetes and endocrinology, obviously the other side of the specialty. I found that I was quite good at like the theory of it. And so thought, right, let's see if I can get a bit of diabetes experience. So many of you may know, but when we first become doctors, we apply for foundation training, which is a job for 2 years where you do 6 different rotations. And my first ever doctor job was an F1 on a diabetes and endocrine ward in Nottingham. And that was just kind of like, oh, wow, this is really good. And the relationships, and actually you're only doing inpatient stuff, but you find that often people coming into hospital have lots of problems. They can be very complex. They're well known to the teams, and even then you get to build a bit of a relationship, and it all just stemmed from there, really.
And then I guess after that sort of training, did you then have to specialize in becoming a diabetes and endocrinology registrar? Is that the process of how you get to that stage, right?
Yeah. So just to run through the structure of medical training briefly. So you do your generally 5 years of medical school. So I did that in Nottingham.
Yep.
You then do your foundation jobs, which is usually 2 different hospitals, like one for 1 year, one for the other. So I did my first year in Nottingham, and then I had to move to Lincoln for a year. I was in the unusual position that one of my jobs in my second year changed. So I actually ended up doing even more diabetes and endocrine because it changed to diabetes. So I'd done quite a bit of it already. And then I was like, yeah, diabetes and endocrinology. But to do that, you have to do what used to be 2 years is now 3 years of general medical training, where you rotate around different medical specialties, and then you do your exams with the Royal College, which allows you to then become a registrar, and then you apply to then be a registrar in whatever specialty you want to do. That's medical, so that's like respiratory, geriatrics, gastro, all those sorts of things, other specialties that you guys may have interacted with for various different reasons. And one of those is diabetes and endocrine, and I applied for it and got it, and I've been hanging around the East Midlands. Well, I've not really left the East Midlands, but I've been here for the duration and rotating around.
Brilliant. So what is diabetes and endocrinology, and what is a diabetes and endocrinology registrar?
So we have 2 sides to our job. So most people as consultants, I think in the UK, still do a bit of both. So they do diabetes, but they also do endocrinology, which is more around hormones and thyroid and pituitary and all that sort of stuff. And we do training in both of those things in parallel, as well as general medicine, like the acute medical unit, people coming in with pneumonia and falls and all that sort of thing at the front door. And often, usually overnight, at the point that I'm at, we're the most senior doctor in hospital overnight, which can be quite intense. And most of the hospitals where seem to fall to the medical registrar on call. And there isn't really an opportunity to split. So you do in other specialties that if there's like a bit of a divide, like the gastro guys split themselves into bowels and liver for the last 2 years, depending on which one they want to do. But we don't really have that in diabetes and endocrinology. But I've firmly nailed my flag to the mast of diabetes, and hopefully won't have to do a vast amount of endocrinology when I finish.
Yeah,
But that's
yeah.
my hope. Yeah.
So,
Yeah.
so what does your sort of day-to-day job then look like at Derby? Are you quite a lot in clinic? Do you go do other like things like research? How would you describe your sort of day-to-day role as a
Yeah.
registrar?
So my job's quite different to most at the moment, because I've got 2 days of research a week, which isn't common. And actually, my clinical work at the moment is in Kingsmill in Mansfield, because I've just rotated and I'm there until April.
Yeah.
At which point I go back to Derby to start acting up as a consultant, which is like our last bit of training. Um, it's a very mixed job. So we do on calls for general medicine, like I say, on the acute medical unit, or seeing sick patients on the wards. They're usually very busy. That's nights and weekends involved. And then during a standard working week, if I was doing a full 5 days, there might be 2 or 3 clinics, maybe more, depending on what it is that you need to get signed off or need additional training in. So, for instance, at the moment, I'm doing lots of antenatal clinic because I need to get my antenatal stuff signed off.
Yep.
And then there's helping on our base wards, so the inpatient diabetes wards, and although it's a diabetes ward, often it's got patients who don't have diabetes who are just in because they've got other medical problems, and there's beds there. And then probably a little bit of time for admin and reading if we're lucky. and then sometimes also going around other wards because they need advice on going to the renal ward because they've got a patient with diabetes and they don't know what to do with their insulin or whatever. We do lots of that and going to advise.
That sounds really interesting, doesn't it? Like you've got that sort of mixed bag of how your job sort of works and looks. And when we've had people like Patrice and Amar and Partha and other people that have come on, healthcare professionals, they've talked about this and they find it really interesting that they get to be involved in as many sort of areas as possible. And I guess it really helps you learn more and see the bigger picture. So yeah, it's really, really good. What would you say you love the most about your job, and also what challenges do you face?
So one of the bits I love, and I don't know if I'm just a bit of a masochist, but when someone's really struggling with their diabetes and there's lots going on and you really just want to get stuck in and involved and learn about them and support them, that is one of the things that I really love the most. Someone who's really complicated, who you really feel that you can help, who perhaps hasn't been listened to before, or is really struggling, like that is something that I really love being involved in. And it can be incredibly challenging, and it can be a bit emotionally taxing from our side a bit as well if you try and invest a lot of energy in someone. But that's one of the things that I really love the most.
And what about the challenges?
The challenges of the job is probably just, and I'm sure you probably hear this from most health professionals, it's the time, it's the external pressures, it's the wanting to be able to do things that we're not allowed to do sometimes, because we're obviously constrained by funding criteria and all that sort of stuff. In an ideal world, it'd be lovely to give everybody everything they wanted, everything they needed, but we're hands tied by the NHS and its funding and what we're able to do sometimes, and that can be difficult, and especially how to have those conversations.
Bonus question I haven't put down. So when someone comes into your clinic, is there a sort of strategy that you tend to approach? So if I walked into your clinic now, is there something that you would do or ask, or do you have a leading strategy of what you want to talk about, or do you see what they want to talk about? Or does it really depend on case by case, I guess?
I think it depends case by case. So if someone had come in and I knew that they were having a very clear problem, it'd be hard to avoid the temptation to go straight into talking about that. But if I've not met someone before, then I usually like to open by learning a bit about them. What do they do for work? Are they into exercise? How are they finding living with their diabetes in general? All that sort of stuff I think is really important, because actually that kind of frames the rest of the conversation, doesn't it? If
Absolutely.
You don't know what's important to the person in front of you, then you can't work on a plan together, and it'd be really easy to be like, oh, you should do X, Y, and Z. But if you don't know that the person wants to do lots of exercise, then the plan might be different. Or if you don't know they've got a very active job. So I think lots of the first time I meet someone, I try to have at least some of the start of the consultation being around, what's your journey been like so far, what's important to you, and then take it from there before we start jumping into blood sugars and all the rest of it.
Yeah, I guess like you say, it's like building that rapport, isn't it? And building that trust and working together. And like you say, you then hopefully work with these patients, I guess. Again, they come back to you a year later or whatever. So yeah, it's having that professional relationship and like you say, from that sort of couple of minutes talking, you might then start noticing things, I guess, like, that makes sense to what I've seen already, and then that can follow that sort of discussion onwards. So do you work with all types of diabetes in your clinics or in Derby itself? Is it like I mentioned a list before, do you have a lot of people from particular different types, or is it primarily type 1?
Yeah, I mean, I think by virtue of doing lots of tech, I tend to do more type 1 than anything else, and lots of type 2, as people will know, is often done by primary care, but we do see people with type 2 diabetes. And then the other types of diabetes are obviously less common, but some of, like, for instance, I'm personally very interested in your type 3Cs, your pancreatics, your or people with like exocrine pancreatic insufficiency and that side of thing. I find really interesting because I think they're a bit of a different beast to everything else, and often are mislabeled as having other types of diabetes, whether that be type 1 or type 2. And sometimes, going on to the gastro wards, you'll see someone who's weighs about 4 stone wet through, who's had really bad diarrhea, who has a label of type 2 diabetes, and you think, actually, this doesn't quite make sense. And then you think about your type 3C and make a diagnosis and really move things forward for them. So see a mix of everything, but I think, mostly type 1s for myself.
And what sort of in the actual team itself, what sort of other areas do you have? Like, do you have a dietitian? Is obviously consultants, dietitian, nurses? What sort of support packages or support networks are available for people? Do you have like education packages that are on offer, like Daphne or Desmond? Like, what sort of things are at your centre?
Yeah, so we do Daphne. I think we do Desmond off the top of my head. We have nurses, educators, dietitians. I think we have a psychologist within the young adult service, but that's something that's happened whilst I've clinically been away at Kingsmill in Mansfield. But I think there's a psychologist now involved in young adults. And actually, one of the things that I really like about Derby is everyone has the same ethos. So unless you want to talk about something really specific, when it comes to sort of day-to-day glucose management, diabetes advice, general consultations, the sort of things that are probably important to yourselves, you'll probably, probably doesn't matter who you see within the team, you'll get the same response, which I think is really important. Obviously, if you want advice on more specific to diet, the dietitians will probably be more helpful. I must confess, I'm not very good at knowing the differences between all the different types of cannulas that go with the pumps and all that sort of stuff. And that's where our nurses are really useful and have a specific set of knowledge that I definitely don't have. And perhaps if you're also having problems with your blood pressure or your kidneys, that might be where we're more helpful as the medical team. But I think we all come with the same skill set with just some special skills on top within each group, and we all just complement each other.
We have a question from Carol. She says, could you ask Tom if he feels telephone appointments are as effective as face-to-face? And she says, I prefer face-to-face. Maybe a little more behind that, I guess, is Derby offering both at the minute, since the pandemic? Does it try and get people in clinics or on the phone? What sort of thing do you guys tend to do, and how do you feel about telephone appointments versus actually seeing a person there?
Yeah. So telephone appointments are useful for a subset of people, and actually, if you're struggling to get your data into the cloud and we can't review anything when it comes to your glucose data or your insulin data, that's incredibly difficult to have any sort of meaningful conversation about your diabetes, so it turns into a bit of a, how are things going? Oh, I'm doing okay. And unless the person with diabetes who you're speaking to has identified a problem that you can help with, it kind of becomes a bit of a pointless consultation for some people. I much prefer face to face. I think there's times when telephone appointments are useful, so I'll often ring people if they've got specific blood results that have come through that need acting on. I find telephones quite good for ad hoc catch ups, or maybe there's some situations where you've just changed something, like I'll just check up on you in 2 weeks and look at your data and we'll just have a quick chat. But I would agree, I prefer having face-to-face consultations with people in clinic. But if someone really wanted telephone because it fit in better with them, then that wouldn't necessarily be an issue either.
No, I think that's spot on, and I think people get that. I think it's like you say, that follow-up chat, or if you've had an appointment recently and you want to catch up with someone about something else, or trying to support them further, that like a telephone appointment might be useful. Rather than if it was, I don't know, a first appointment with yourself, it'd be like people might prefer to come in person. But I guess it's that option as well. We talk about technology and options and stuff like that. I think it's that option for people, and that's maybe a lesson learned from the pandemic, isn't it? Is providing.
And I think coming to clinic, sometimes it's a nice stop moment for people to reflect. They might have 10 minutes in the waiting room to think about what they want to talk about, and then they come in and you can have a bit more reflection about your own diabetes in that time as well. I've heard some stories of people ringing people and it's like, oh, I forgot I had an appointment, I'm just on top of a roof, but I'm happy to take it. Do you know what I mean? It's kind of like, ooh, and then that becomes a bit less useful for everybody, and also potentially risky.
Yeah, absolutely. So Diabetes Chat do not advocate for doing your appointments on top of roofs, guys.
No, or even driving to an extent.
Well, but in my situation where I'm a teacher, and some appointments or catch up to whatever, it has been over the phone, and you're waiting all day for the phone, and then you're just busy, and then something happens and you miss it, or you know what I mean, or they ring and you're kind of half listening because actually you have to be elsewhere at the time, and you probably don't get through the appointment as much as you want to, and then you kind of think, you know what, we need another appointment now because that was just so quick. So I wanted to throw a statistic at you. So according to diabetes.co.uk, currently the number of people with diabetes in the UK is estimated to be around 4.8 million, with a predicted up to 1 million of people in the UK have diabetes yet to be diagnosed. What do you think needs to be done more so to raise diabetes awareness and help educate others, especially for them people who living with diabetes and they're unaware of it? Because I'm sure there are quite a few people that are in them shoes or have been in them shoes. What's your thoughts on that?
Yeah, and when you hear those statistics, I mean, the assumption is that most of those million people who don't know they have diabetes probably have type 2, because most people with type 1 know about it, don't they? Because of the symptoms and everything else that goes with it when it first comes on. But like type 2 is a bit of a different beast. And actually, one of the things that I worry about is that people put off testing because they're scared or worried about stigma or judgment from other people. And I know there's been lots going on about stigma recently, but actually it's something that you could, I think knowing is better than not knowing, because it allows you to take action, doesn't it? So I think we should just be encouraging people to get HbA1c testing, watch out for the symptoms, and I would encourage all healthcare professionals to think about doing HbA1cs if they see someone who is at risk, and just think about it a bit more, and then have those conversations, really.
Awesome. Question from Belinda, who's listening in from Australia. She says, what does Tom find most challenging about diabetes in pregnancy? #DiabetesChat.
So my personal, so I put off antenatal for a very long time, and that was because I had anxiety about pregnancy and not knowing an awful lot from the obstetric side of things, and that really worried me. And I think the challenge with diabetes in the context of pregnancy is that everything changes so quickly, and you almost feel like you're always on the back foot, and it's really, important. One of the things I've really learned, and one of the phrases that one of our DSNs use, is we just react to what we see, and making sure it's not necessarily, and rarely it is, the person in front of you that's not doing the correct things. It's just because in pregnancy things change so rapidly. So when people aren't meeting their targets, it's usually not through any action they're taking or not taking. It's more because that is the nature of the beast. And I think you've got very clear goals, making sure that you're reacting to what's happening, and trying to protect both mum, but also trying to ensure that there's a healthy baby at the end of it as well.
Yeah.
And one of the things I found is it can be challenging, it can be scary, but actually it's incredibly rewarding once you get to the other side of it. So,
and again, it's the people within Derby that are more specialists in that area, who obviously, if someone comes to you, you have amazing knowledge, but it's that other people that you can then pass to get that more regular support if they need be.
Yeah, so within antenatal, there's so some of our DSNs do more antenatal than others, just so that they keep their skills up. That, and same for dietitians, and same for consultants. And actually, at Derby at the moment, only two of the consultants do antenatal, so they're getting quite a lot of exposure, seeing people week in, week out, getting good continuity. So I think that's really important.
Brilliant, thank you so much. Great question from Belinda over in Australia. If you guys have any questions for Tom Crabtree, please hashtag diabetes chat, or if you're on YouTube, you can write it in the chat box. So obviously I said in the intro, Tom, that you're current chair of YDEF. What is YDEF? And can you share a little bit about the role that you have in it and others, and the sort of things that it's been doing?
Yeah, so that's very recently changed, actually. I stepped down as chair on Friday last week, so my year was complete. So that's very recently changed, and
I never saw that on the internet, Tom. I did my homework, but I never saw that.
But YDEF, so it's our registrar organisation for Diabetes Endocrinology Regis in the UK. Lots of what we do is we deliver courses to cover key bits of what we need to learn. So, for instance, we have a technology course, which is like a 3-day residential course. It runs twice a year. It's supported by industry, and usually there's about 30 to 40 registrars go. They get the opportunity to wear a sensor, wear a pump with some saline in it, get some hands-on experience of pressing the buttons on the pump, trying to do some carb counting when we're giving them their meals that are included in the course, and getting used to how do you sleep in bed with a pump attached to you, kind of thing, which can be quite interesting and gives people some new insights. We also we've got a range of courses. So we've got an obesity management course. We do a course for younger registrars, which we call the ABC of D&E, as in the ABC of diabetes and endocrinology. And we have our YDF day, which is returning to being the day before the Diabetes UK conference in April for next year. So basically lots of training opportunities, and we work in the background, advising or giving our views on things like workforce planning, or what changes should they be making to training to make sure that when we finish, we're equipped with the skills to best support you guys.
Yeah, that's great.
And that side of things. So there's lots of behind the scenes stuff, and then some more obvious things that we do around putting on courses and providing educational opportunities.
That's brilliant, and we've already touched on about education already tonight. Okay, let's talk a little bit about your research fellow role. You said obviously you do 2 days research. What is entailed in that role? What's some of the things that you've been involved in or part of? Is anything that you're willing to share? I know we talked offline about the hybrid closed loop pilot study that you're a part of.
So my research hat comes in sort of, I've got 3 different research hats. So lots of it's been around the type 1 technology side of things, working with Emma Wilmot, very heavily involved in the closed loop pilot, analysed all the data and wrote the paper that was published in Diabetes Care with the results. If anyone's interested, you can find it. It's open access if you want to see the results of the pilot. It's all there in Diabetes Care. So that was one of the big projects that we've done, but we've also done lots of other audits to collect real world data with ABCD, who funded my fellowship and continues to fund my 2 days a week. ABCD is the sort of consultant diabetes body for the UK, also representing registrars as well. And so most of what I do is around real world data. We talked about tech. The other bit is around some of the newer therapies in type 2. So we've done lots of work looking at real world results from like your SGLT2 inhibitors, from your GLP-1 injections, and all that side of things. And then on top of both of those, I've then done a thesis which is looking at really big data from loads of GP practices from this online sort of database, which we call CPRD. Just looking at actually in type 2 diabetes, is the best HbA1c target the one in the guidelines, or are there certain characteristics that might people have that shift that and make it higher or lower to prevent different complications? So that's one of the other bits I've been doing. But all of this is real world data. And one of the things that I love about real world data is it can be really rich, it can be really messy. But actually, when you look at randomized control trials, I don't know if anyone in the chat has been involved in a clinical trial at any point. And I'd be interested to hear, but you'll probably experience loads of support, 2 weekly phone calls, regular blood tests, because it's so well resourced, because you've got all this research funding that comes with it. And then actually, what you really want to know is how do these things perform in the wild? And I'd say it's a little bit like if you want to learn about lions, you probably learn an awful lot about lions by looking at them in the zoo, but what you really want to do is go and see them on safari and see what happens in the wild. And that's the same when it comes to new drugs and when it comes to new technology. So I think there's importance to both. Like, you would never want to approve or say that something new was safe or didn't have side effects just looking at real world data, but actually you need to see what it does in the real world, because ultimately you'll give it to people and they might go say they're taking it or not, or they're not getting the same support, and you want to see how that translates.
Absolutely. And like, again, comes full circle around, doesn't it? Like, each person's so individual, and who knows of what sort of journey that will go on. So what about the hybrid closed loop pilot study then? You obviously were part of that, a big part of that. What was it? What was your involvement in it? What were the sort of findings coming out of that study, the impacts? And you've talked about how data is your sort of thing. What were the sort of significant elements coming out of that?
So this all started in 2021, and it was sort of suggested by NHS England and pushed forward by Partha to try and get some real world evidence to support what's happening now around the NICE guidelines and the technology appraisal. And it was a very specific subset. So it was people who were already using pump, people who were already using a Freestyle Libre. At the same time, other sensors weren't readily available at that point. And then finally, they had to have a HbA1c that was above target, and that was above 69. And they did it in the centres that are using lots of pump already, which is why if you're in certain areas, you may not have had opportunity to access this. And it just gave us the funding to put loads of people on it in this course of about 3 to 4 months, and then to collect some data back. Just the stuff that we would do in clinic anyway. So we weren't doing anything extra or new, but we were just giving people the technology that was already approved and seeing what happened in terms of HbA1c, time in range, and all that stuff. And I think the results speak for themselves, and that has fed into some of what NICE have looked at. There was reductions in HbA1c, improvements in time in range, and I think probably the most powerful thing is the reductions that you see in diabetes distress and improvements in quality of life, which I don't think can be understated. And when you speak to people in clinic and thinking about closed loop, although glucose is important to people and improving glucose levels invariably does make people feel better, actually reducing that burden of day-to-day diabetes management is probably the biggest plus side of the technology.
So what is a hybrid closed loop? For people that are listening now that don't really know much about it, and obviously we won't go into a big discussion about it, but briefly, what is hybrid closed loop? And what should people expect from that? Because you might see some things on Twitter or in the media or stuff to say that it's a full artificial pancreas and it will solve all your issues, that sort of thing. But what is a hybrid closed loop?
Yeah, so and I think I think the media goes for artificial pancreas because it's the way to make it easiest to understand.
I guess from sort of a muggle sort of point of view, someone who doesn't know about diabetes.
So the way I explain it is, so you've got an insulin pump which has existed for a long time, and the pump delivers a constant infusion of insulin. But in the past, that pump's had to be programmed, individualized to the person to give that constant drip feed of insulin to give you a background. And then at meal times, what you would do is you put your carbohydrate intake in, and it would give you a bolus for your meal time. So it's a bit like anyone using multiple daily injections, but rather than having your background fixed as a 1 or 2 injections a day, not much variation, not much nuance to it. You can vary that, and that's perhaps important if people are, exercising consistently at certain points per day, or they find they're more resistant in the morning. All that sort of thing means that you can individualize what the pump is doing. You've obviously got glucose sensors as well, so that could be your Libre, your Dexcom, all those sort of things. And what the hybrid closed loop does is marry those two things together, such that the pump will look at your glucose levels, and for your background, it will adjust itself automatically to keep you in that target range. Now, it's a hybrid closed loop because it's not fully closed loop. And what that means is you still have to engage with it when you're eating and drinking. So you still have, drinking if you're drinking something sugary, I guess. But when you're eating, you still need to tell your carbohydrate intake. You still need to remember the bolus before you eat. And to get the best results, you need to do that. And what I would say is it will pick up some of the slack. So your carb counting doesn't need to be as accurate, and it will give you a little bit more leeway for that unpredictability. If you're having snacks that don't have a vast amount of carbs, it will probably manage that as well. But for the majority of people, to get the best results, you need to be engaging with it around meal times, is what I would say. So it does reduce the burden a bit because you maybe have to worry less about hypos. It'll cut out to try and prevent that from happening. If you're going high after eating, or you've missed carb counted, it will bring you back down into range, albeit not too quickly, but it will do that.
Do you think it's hard for someone living with diabetes and they're using the technology, and if the levels are getting quite high, it's kind of thinking, oh, what do I do? Do I need to intervene? Do I need to step in here and deliver some more insulin? Obviously, you don't want to stack the insulin. Do you hear that from people that come to your clinics, that sometimes it can be a bit overwhelming and they don't know, oh, should I step in here, or kind of put your foot off the gas and let it do its job, essentially?
Yeah, I mean, I think it probably works best the less that you interfere with it and just try to let it run in the background as much as you can. And I know that's really difficult. And one of the examples I use is, like, I've got a car with adaptive cruise control, and handing over the steering wheel of a car to adaptive cruise control to keep it from the car in front of you and also to try and keep you in lane can be nerve-wracking the first few times you do it. So handing over your diabetes to a machine takes a lot of time to build up some trust with that machine, to know that it's not going to send you in the wrong direction. And it's just a different way of managing diabetes. You have to think differently about certain things, especially with closed loop. Your hypo treatments should probably be less, because if you have a standard hypo treatment, because it pushes you up quite quickly, the system might think, oh, you're rising fast, give more insulin, and that's not what you want when you've had a hypo. Exercise is perhaps a bit different. So carb loading before exercise on closed loop would be a no-no. And then when you're high, knowing how to respond to that's really important. So if you go up because you've just eaten and you come back down, that's probably okay. But if you go up and it's a sort of level that you might think, oh, well, maybe I'm just a bit unwell or under the weather. Well, actually, in a closed loop, that could be a sign that there's been a problem with the system. Is the cannula kinked? And that means that you might need to do some intervention in terms of changing your sets and things. And that's all advice that we give to people when they start closed loop. But it's really important that people recognise that it's different to managing MDI, or even managing on a pump on its own.
Brilliant. Thank you so much. Obviously a little bit about the criteria, but we'll not go into too much. More from an educational point of view for the community listening, part of the criteria says about disabling hypos. What is disabling hypos?
So I don't know the exact wording, and I think it is written down in the NICE guidelines, so I do apologise if I have got this incorrect. But it's basically hypos that are intrusive into your day-to-day life. So that could range from your severe hypoglycemia, where other people having to help you treat them, but that could be that you've got like an extreme fear of hypos, so you're doing lots of exercise and finding that you're hypoing all the time. So there's a little bit more nuance to it. There is an exact wording in the NICE guidelines, so please refer to that. But that tends to be what disabling hypos are around. So it's not necessarily just around severe hypos. It could be around an extreme fear of hypos that are preventing you from reaching goals and things. So that's a bit more broad.
Brilliant. Obviously, the hyperclosed loop is sort of in its final stage of TA, I guess. What would you say is the best way for, not just talking about hyperclosed loop, but as a person coming to your clinics, what is the best way for them to build a case, or the best way to approach you or the team most productively, so that they can ask for technology or ask for treatment or ask for education? What would you say is the best way to go about that?
So if you've seen something, talk to us about it, and we will be honest. And what I would say is we are hands tied by guidelines, and the NICE TA will be great, and it will give access to closed loop for more people. But I accept that it's the first step of a long journey. To the point, I mean, in 10 to 15 years' time, I would hope that it would be standard care, and anyone who wanted it would be able to access it. But we don't know what that journey is going to look like, and the NICE TA and all pathways hard work is the first step in that journey to getting it into hands of people. And I would also plead for patience, because we are going to have to make, or each service is going to have to make decisions about who the priority is, who gets it first, because we're going to have an awful lot of people who meet the criteria, but we only have a limited amount of resource. And so I would ask for understanding where possible, as we try to make those difficult decisions, and know that we'll do everything we can to get everyone who meets criteria on it within the 5 years or so that we've been given to do so by NICE.
Yeah, absolutely. Brilliant stuff. If anyone has any questions, hashtag Diabetes Chat. We chatting to Tom Crabtree for the next 15 minutes. So, connected pens. I know this is something that you really like, and you we did a chat, didn't we? I think it was in February. What are connected pens, and what do you like about the pens, and what sort of pens are currently available or will be coming available soon?
Yes, so I really like connected pens, because there's everyone's free to manage their diabetes sort of as they want, and closed loops and pumps are great, but they don't work for everybody. Some people really like MDI and the freedom that it gives them to not be attached to loads of different bits of technology and kit, and I totally appreciate that. There's two things that I think really helpful with connected pens, or maybe three things, with a bit of overlap between two of them. One is the power of data, and it's so much more useful and allows us to have such more informed discussions as healthcare professionals with people with diabetes, when we've got not just access to glucose data, but access to insulin data as well.
Yes.
But it also is really useful to allow yourselves to reflect on things a bit easier. You know, lots of people will have done Daphne or other similar structured education, and in the era of like Libre and Dexcom, having to like try to do a Daphne diary feels a bit like you'd have to go back to pen and paper, doesn't it, to try and understand. Whilst actually, if you've got all that in one place, that allows you to do that self-reflection that's been perhaps taught to you through doing those courses, and then adjust your own ratios or make changes or have a bit of trial and error yourselves. And then I think the third thing is around sustainability. And this wasn't really something that was on my radar until about a year ago, maybe 2 years ago. I remember seeing this girl in clinic. She had relatively newly diagnosed type 1, and she just said to me, "Man, there's an awful lot of waste associated with diabetes." And I thought, "You're not wrong." And she might have been one of the first people I put on a connected pen from memory. And it's just knowing that people are concerned about it and recognizing that there is an awful lot of waste associated with diabetes healthcare. And that doesn't mean that we shouldn't be doing things because it produces lots of plastic waste, but it does mean that we might need to be a bit more savvy about what we offer to people. And if people want to use disposable pens, then that's fine, but actually knowing that there's another option there on the table can be useful, or let you have those discussions with people.
Yeah.
You asked about the ones that are available at the moment. So at the moment we've got, if you're on Novo insurance, there's a Novo Pen 6 and the Novo Pen Echo Plus.
Yep.
So the Echo Plus is their half unit pen. So I sometimes say it's the pediatric pen, but I guess that's technically incorrect because there's no reason why an adult couldn't have a half unit pen as well. But they tend to use them more.
And I think that's great, isn't it? Having that choice, because actually that 0.5 of a dose may be the difference. You know what I mean? Like it could be. So having that option on the table is great.
Yeah, and then so that's like the mainstay of connected pens at the moment. There's the Medtronic InPen, which fewer people use. That can be used with any insulin and connects to their app, and also to a Guardian sensor if you wanted to use a Guardian sensor on its own. And you've got that option, and that's got some interesting integrated bits in terms of bolus calculators, and it uses your insulin on board to make to advise on dose adjustments, I should say. So that's quite an interesting offering. And then some of you might be using insulins that are made by Lilly, so like your Humalog and your Lumjev. I heard you talking about what would you name an insulin? Probably something more easy to pronounce than Lumjev, but I'll leave that to the marketing department at Lilly. But they are, so Lilly's potentially bringing out one as well, but that's been on the horizon for about a year, and we haven't had any updates. So I don't know whether they're still going down that route. And Sanofi, I believe, might be bringing theirs to market. So if you're in Atlantis,
I think trying to think now, I've been on mine about 15 months, I think it is, and I didn't know anything about smart pens. It's when I went on a Libra course and they said, "Oh, would you want one of these?" And I was like, "Oh, yeah, for sure. It's a free gift. I'm taking that." And I've just really, really loved it because I can obviously see how many units I've taken and when I took it, and it links to my apps. I'm from personal experience of using the Nova pens. I've not used any of the others. Is it links with Libra now, Libra 2? I don't know about 3, but I assume it does.
It doesn't actually link with Libre 3 at the moment. I'm trying to find a back door. So I wondered if because the Libre 3 is a separate app, isn't it?
Yes.
For anyone who uses Libre 3, you'll know it's a different app to the standard Libre Link app.
Yes.
And that at the moment doesn't let you upload smart pens, but I think if you have both apps, you can put your insulin data into Libre Link, and then you've got your Libre data in Libre 3. And I don't know if that's true or not, because I'm just testing it on someone at the moment.
Yeah,
but I'll let you know.
No. And that's what currently I'm on the Dexcom G6. And if I want to use an app to see all my sort of insulin levels and stuff, I have to use, I don't know, like Gluco, or I might use Xtrip or Nightscout and all them sort of things. But you have to use Gluco or a different app. And that's one of my sort of frustrations, that for a person with diabetes, like we've said already tonight in our chart, we're making these 180 decisions, we're spinning plates and all these decision makings on top of everything else. And I think the technology, how it's evolving, is fantastic, and the way that we're learning from it, great. But it's things like that where I'm having to use a third party app to then put the data in, and in our busy lives and everything going on, you might not do it as frequent as you want to. And that's my only sort of thing, is where I hope these companies will have one place where all the data. So if I'm using this or this, that goes to there, and I guess that will help you as well as a healthcare professional, rather than opening 12 different browsers, right?
Literally the bane of my life. And to be honest, the problem is when you move hospitals, you often have to get a new account on each of them.
Yeah.
So they're all nicely in sync. All the passwords are the same, but then the passwords expire at different rates. Then you start to forget your password. So usually at the start of clinic, there's a good 10-minute period of me frantically resetting passwords, waiting for multi-factor authentication emails to come in, trying to find signal for my phone so I can get a text to log into LibreView. It's just a recurring theme. So I mean, I think one of your biggest asks is probably one of our biggest asks, which is please companies work together and just have one place to put the data.
Yeah, they keep saying coming soon, isn't it? That sort of expression.
I mean, lots of people are using Gluco, aren't they? So I mean, maybe it's that's the direction most companies go in.
Yeah,
I know Libre at one point, for anyone who's been using Libre for a while, may remember that Libre went into Gluco at one point, but that changed.
Yeah. I just wish that it was all in one place on my G6, so I can see my levels. I can see when I've given my insulin. I can see patterns. I go, that might be because of that. So I can see it all in one place and put my logs and everything there. And then when I come to clinic, you guys can see it rather than opening 2 or 3 different apps. And I think that'll help. And currently, I sometimes feel with my pen is what I'm mainly benefiting from it is seeing it as I can check to see when I last injected and how much, and I think that is a massive thing.
I mean, it's so simple, isn't it?
But it's so simple. But it's my frustration is I want to do more. I want to see more. But I think that being able to see you've given insulin and when and how much, I think that's great because we've talked about so many times here is how many times have we been in situations where we don't know if we've given our insulin. What do we do then? Do you give half? Do you give your normal dose? Do you not give any? What would you advise in that? So if someone's using a disposable pen and they're not sure what they've done, what would you advise as a registrar?
It's really difficult, isn't it? And I guess it depends on the person and to what's most concerning for them. Are they worried about going high? Are they someone who's more prone to hypos? And that might make you ask differently. And I think if there's any doubt, trying to have a discussion with your healthcare professional team to say, if this happens, what should I do? Is probably really important. But actually, connected pens are a really easy way to get around that because you can literally see how long it was since your last dose and how many units you gave. And then there's something else I was going to say, but one of the things I like about connected pens is if you're not into tech and apps, you can still use it, and then you can still bring it to clinic, and we can download it in clinic. So it's really useful. Sometimes it's really useful for people who are older, maybe it's starting a bit of dementia, maybe not using a smartphone and things. It can be really useful for them, and also to help support their families in helping them manage their diabetes. So that's the other consideration.
Brilliant. Thank you so much, Tom. So it's 9:25. To finish then, what does mental health mean to you, and what do you do to improve your mental health? And also, what support is available in your clinic, in Derby, to help people with their mental health, whether it's general or in terms of diabetes?
Yeah, I mean, I really wish everywhere had a psychologist. I wish we all had more access to psychology. I think the mental health burden of diabetes is massive and hugely underestimated. And I think sometimes one of the things that I think is really powerful when people are having problems with their mental health, or to be fair, when there are other things going on in people's lives other than their diabetes that are major life events, I think it's really important to say, in this moment in time, in the grand scheme of things, your diabetes doesn't need to be perfect. You need to look after yourself. You need to do everything else that's important. You need to get on top of your mental health. And if you fix your mental health, or manage to get through whatever difficulty you're having at the moment, the diabetes will follow. In the short term, we want to keep you safe. We're here to support you. We're not looking for perfection. We're just looking for you to get through this, and we're here with you on that journey. And I think having reframing it as your diabetes doesn't need to be good right now. There's other things going on. Let's just get you through, kind of thing, can be
this stage.
Can be quite powerful.
And what do you do for your mental health? How do you sort of improve your mental health, and what does mental health mean to you?
I know there's plenty of things that I should do for my mental health. I should probably say no to more things. And I should probably go back to some of the good habits I had, like running, which have fallen a bit by the wayside.
But it's winter now. Come on.
It is winter now. Well, my excuse for not running is that I'm trying to finish writing my PhD, and so I need my mornings for writing rather than running. But sometimes it's just nice to chill and try and take a break and detach yourself from work, and that can be really important. I think talking to people is probably the most important thing of all, and people who have shared experiences will know where you're coming from. And for yourselves, that's peer support and obviously the power of Diabetes Chat. By the way, I've not congratulated you on your QIC win.
Oh, thank you.
Which we the Derby Facebook group was also in there as a
they were a fantastic group.
Honourable mention, but I can see Sean's listening, but the Derby Facebook group is both a blessing and a curse because it does excellent peer support, but whenever there's a new development in diabetes, we do get flooded with requests. But that's not a bad thing. Obviously, it's keeping people up to date.
Absolutely. So I think that leads on actually to our last sort of section is why is peer support so important, and what's your views on peer support?
So I think peer support is incredibly important, and there's lots that I can empathise with because I might have had similar experience or other bits and pieces, or I've learned from speaking to people what this is like. But I cannot tell you what it is like to live with diabetes, and sometimes you need to speak to someone who's going through the same thing as you and can give you advice and say what's worked for them and what's not worked for them, or just to talk about how terrible we are as healthcare professionals and how we could be doing better. And sometimes that's very therapeutic.
I think you're right on the first point. Just having people that you can just talk to and relate to and understand, and people who just get it and wear that t-shirt and go through day-to-day life with it. And I guess it's like how I've seen it in the past is when I've got my friends who we just hang out and we've known for many years, and also I have football friends. It's kind of having a group of people that you have something in common with and you can talk to, and I just think it's so important to try and connect with someone that who understands. And I just think no one should feel alone, no one should feel isolated or embarrassed. And I think the online communities are fantastic, and you mentioned Sean and Type 1 Derby group. They're absolutely amazing, and I see the floods of messages coming through. It's great that people are supporting each other, and thank you for your kind words for Diabetes Chat. And I just think, and what I kind of said on the back of the QIC was it was just so fantastic to see the bigger picture here of the importance and the value of peer support. That of course it was really cool for Diabetes Chat to win, and there were 4 other amazing groups, and there's so many more, hundreds, thousands around the world.
Hundreds.
But I think the biggest thing for me was just how it was signifying the importance of peer support. You know what I mean? And it was a great opportunity for that to be that moment.
Agree. And I think it's just so. And in fact, I remember the first time I really came across the idea of peer support during my training. It was actually when I was doing my Daphne training a couple of years ago, and you're in a room and there's 10 people, mostly with type 1 diabetes, or obviously that's a general idea, but there's people who've had diabetes for 35 years in the room and they've never met another person with type 1 diabetes, and that seems mad to me. And so they've probably been living their whole life in isolation or thinking that and sometimes it's just nice to know you're not alone, isn't it?
Absolutely. And you know what I mean, I see so many fantastic online communities like this and Dive Group and so many, but there are so many people who probably aren't on social media and stuff like that have no idea of this sort of peer support, and their only human contact maybe with someone with diabetes is if they walk into clinic and they go to reception to give their name, and they might see someone across the room and you might kind of give them a little like a hi, but you know what I mean, like so
this is one of the things that so Emma Wilmot always says this about the Derby Type 1 group, but one of the things that she noticed changed following the start of it and the peer support work that they're obviously doing and working really hard at is that people would sit in the clinic waiting room and actually talk to each other, and that wasn't happening before, and that like even having that is like such a big big difference. Exactly.
Big difference, and it helps again bring it back to that mental health. Is there a role where you feel the sort of communities, peer support can help you guys as healthcare professionals, is there any capacity you think can go down that route, especially with like the rollout of the hybrid closed loop and the 5-year plan and things like that? Is there anything, what can the community do, like to help you guys, to help each other out? What would you say?
So, I mean, I really think raising awareness and just talking about the options that are available, whether that be closed loop or otherwise, like we spoke about connected pens tonight. But I think people having a knowledge of what is out there is important, because if you don't know, you can't ask. You're not empowered to speak to us about it. And I think sometimes the peer support community will help in highlighting. That sounds like you had a funny consultation, like, you know, flagging things that people might not perceive to be a problem. And then the other thing that I'd be interested in the future, and there'd be work that would have to go into this, but I do wonder about the role of peer educators in future. Obviously, our DSNs and dietitians are very well trained and highly trained professionals at being educators, but training people with diabetes to be educators could well be a possibility. And you'd want to do it in a formal way. You'd want people doing it to be incredibly supported. You wouldn't want them to be advising people on diabetes that might introduce people to risk. So that would be the other consideration. But, you know, why not get people in to talk about their experiences on closed loop when you're doing the closed loop start, because that might make it feel more real or highlight some of the problems that we don't think about as healthcare professionals. If like myself, they're not also living with type 1. So
brilliant chat. It's been really empowering tonight, Tom. Thank you for your time, for coming on, rushing back from your day and sending your partner off to bed and chilling in your front room, chatting away to us.
It's all right. I've had a load of needy messages off him saying, "You made me go to bed. I need a drink. You're horrible." So I now need to go and take him a drink, I think. So,
absolutely. But honestly, thank you so much for coming on tonight, chatting to us. Thank you for everything that you're doing in diabetes job, supporting people as a registrar, and thank you for just being awesome, chatting away to us tonight, answering all our questions. And
no, really happen to. I'm very much an open book, so if anyone wants to at me on Twitter or ask anything else, then that's absolutely fine. I'm happy to help. No clinical advice though, because that's bad.
Yeah. But it's maybe having them sort of brief discussions, and then you, like we keep saying, and many people keep saying it, healthcare professionals as well as we as a group, is then go speak to your healthcare professional. They're the people that really know you, isn't it? They really get you. Exactly. They see the data, they see your path, they see the journey that you talked about before. You might see something that comes on people's posts or a discussion, but it's then go seek further information with your team. But brilliant stuff. Thank you, Tom.
And just to close, I've had a message from Sean saying, "Sorry, we sometimes give you problems," but Sean, the problems in a good way. I promise. We really appreciate all the work you guys do on the Facebook group. And actually, if you weren't spreading the word, we wouldn't be getting tested, and people wouldn't be aware of what's happening out there. So thanks so much.
And I spoke to Sean offline a few times, and he talked about other hospitals offering these amazing groups and peer support communities like the Derby One group, and I honestly feel that's every centre, every hospital should have its own little group.
I agree, but the only, I know we're going slightly over now, but the only thing is you need to have really driven people with diabetes to moderate it and run it, because if we do it as healthcare professionals, it doesn't land the same way. So if you're in an area that doesn't have a Facebook group, speak to your healthcare professional team, set up a Facebook group, and just get them to signpost people to it. They don't need to be involved in it. They'll be hands off. The only interaction we have with the Facebook group is through Sean, and we know if there's something happening locally or we want to share information, we pass it on to Sean or another one of the team, and they'll post it on there. But we're not on there. You can talk about us all you want, say horrible, nasty things, say that Dr. Crabtree said that I was being badly behaved and all that sort of stuff, which I don't think I ever would, but you never know.
Not at all. Not at all. Brilliant. Thanks, Tom, for your time tonight.
No worries.
Take it easy, and we'll I'm sure catch up again next year at some point.
Yeah, no worries.
Brilliant. Thank you so much.